Hey everyone, so this slide set will be on the topic of anemia. So first, a definition on anemia, which is the inadequate concentration of mature red blood cells in the peripheral blood to satisfy the tissue oxygen demands. Now, there are direct cutoffs from the KDIGO guidelines that define anemia as less than 13 for males as well as postmenopausal females, and less than 12 for a premenopausal female. This just accounts for the fact that as younger women go through their monthly period, they're going to lose blood, so naturally their hemoglobin is slightly lower. And hemoglobin here is the preferred measure for the diagnosis of anemia. We typically don't want to use hematocrit, even though that's another lab value we commonly see, because hematocrit does vary based on their fluid status, so whether they're hydrated or dehydrated, and also lacks standardization among different testing instruments. So here on this slide are a few of the correctable causes of anemia you may find. One being malnutrition. Vitamin B12, folate, and iron are common nutrients that do affect whether a patient has anemia or not. The serum PTH and TSH as well here manage their thyroid conditions. Infection and inflammation can lead to anemia, so you want to treat that underlying cause. And then just generally blood loss. So try to stop the bleeding. They may need blood transfusions, but that could be a cause of anemia as well. So on this slide here shows some of the signs and symptoms of anemia. You can pretty much see it anywhere. All of these are related to the fact that different organs and body systems are not getting enough oxygen. So you're going to have more fatigue and have dizziness as it doesn't get to your head. So impaired cognitive function as well. Your GI system might be off as there's not enough oxygen to the GI system. You may have some low skin temperature. Your skin may become more white as the blood tries to be conserved towards more of the essential organs and less towards the extremities. Immune system impairments, some cardiorespiratory system issues, as well as some genital issues. So here is a table of all the different labs that you may be looking at for anemia. So we had talked about hemoglobin and hematocrit a little bit already. The mean corpuscular volume, or MCV, is another important one, which characterizes the size of the red blood cell. So if it's smaller, it may be a sign of iron deficiency anemia, but if it's on the macrocytic side, maybe a sign of more B12 and folate deficiency. We have reticulocyte count, which is an indication of immature red blood cells, so how fast are these being produced? And then we have a couple of different iron labs that we look at just to assess the patient's iron status. So first we'll talk about iron deficiency anemia. So this iron deficiency anemia is the most common reversible cause of chronic anemia and can be worsened in patients with CKD or chronic kidney disease. And some of these patients that have iron deficiency anemia may be hyper-responsive if you try to give them ESA or erythropoietin stimulating agent treatment, which we'll talk about later on in this PowerPoint. So the goal of giving them iron supplementation is to correct the iron deficiency and ensure that we do have adequate iron stores for erythropoiesis, or the production of red blood cells, and especially in patients who are receiving ESA therapy and trying to stimulate that production. So the first thing you would like to do is to assess the iron status, looking at the serum ferritin, which is the most common test for assessing iron deficiency or overload. Now, of note, this can be an acute phase reaction, so if patients are in an inflammatory or infectious state, this may be higher than expected and may not be a good indicator. Next, we have TSAT, or transferrin saturation, which indicates the amount of iron available for erythropoiesis process, and typically absolute iron deficiency is defined by TSAT less than 20 and ferritin less than 200. Now here are all the different types of iron supplementation that you can give a patient orally, and within each salt form I've listed in the table for you the elemental iron percentage that each has. Now the main thing to know with these oral iron products is that they do cause a lot of GI side effects, maybe some nausea, definitely constipation. Their stools may be very black, dark, and it's important to distinguish that from a GI bleed. Now some of the ones at the bottom of the table have been marketed to produce less GI upset, but I haven't really seen them used all that often, and they are more expensive. Also, in certain patients, like patients with kidney dysfunction may not absorb oral iron as well, so you may need to use IV iron options. So here are the list of the IV iron options. The top 3 have been around a lot longer and are a little cheaper. The bottom 2, newer options, can be given more quickly and over a shorter number of doses and are a little bit more expensive as well. Now, the main thing I want to note here is that iron dextran, the first one that you see up here, it is absolutely required that you do a test dose first before you give the full iron loading dose, because people can have anaphylaxis to this, and that test dose is essentially a safer dose so that we know whether they can receive the full dose or not. The rest of these doses do not require any kind of test dosing. So on this slide, we have some of the drug-drug and food-drug interactions that I want you guys to be aware of as far as iron is concerned. So some of the aluminum, magnesium, and calcium antacids, as well as tetracycline and doxycycline and cholestyramine, can bind to the iron in the gut and reduce its absorption. H2 antagonists and proton pump inhibitors can also decrease iron absorption because iron needs an environment of acidity to be absorbed well. There are also drugs that may have reduced efficacy when given with iron, including levodopa and methodopa, your levothyroxine, penicillamine, a few antibiotics and fluoroquinolones, and doxycycline, as well as mycophenolate. Now, there are also foods that decrease absorption, essentially with the same mechanism that was discussed earlier, and that it can bind to the iron in the gut. These include some phytates, which are found in grains, brands, vegetables, polyphenols, tea and coffee, and then phosphates and calcium, so your dairy products and your eggs. And this is just important to know in that typically we recommend patients who take oral iron to take it on an empty stomach so that it does not bind with some of these different food products, because it's kind of hard to avoid all of those on that list. So now we'll talk about these erythropoietin stimulating agents, or ESAs, that we briefly mentioned in a few slides before. So these can be used in patients who are going through chemotherapy if they have cancer or have anemia due to chronic kidney disease. And you usually consider it if the hemoglobin falls to less than 10. So you have 3 different options out there on the market. We have Epogen, Aranesp, and Mircera, with the generic names listed there as well. The main thing to know with these is that these medications are effective in increasing hemoglobin. One, if the iron load is appropriate. So you got to check the iron levels. If there's no iron on board, these agents do nothing. Second thing here is these precautions noted. Studies have shown that if the hemoglobin actually gets too high, there's some morbidity and mortality associated as well. So typically, if the hemoglobin rises to 11 and they're on this therapy, we're going to stop the therapy. There are also rare cases of pure red cell aplasia and some other side effects that were seen in the trials in greater than 10% of patients, including hypertension, edema, abdominal pain, dyspnea, and cough. B12 deficiency anemia, we'll talk about next, another nutrient deficiency that can lead to anemia. Now, this can be caused a lot of times by different gut factors. So B12 requires an intrinsic factor to be absorbed. So if your body does not produce enough intrinsic factor, which is produced in the stomach cells, then you can't absorb any of it. Other diseases that affect the gut may also affect your ability to absorb B12. So to treat vitamin B12 anemia, we do have supplementation options through either oral or through intramuscular, as well as deep subcutaneous vitamin B12. We do also have this intranasal, but honestly, I've never seen it before. You can only use it in maintenance therapy. So essentially, if you've gotten their B12 levels up from the oral or IM options, and then they really want to use intranasal, they can. I don't really see the point. I think if they've been able to take orals, just keep going with the orals. And you see some of the doses that are listed there. The main thing to know is that the IM and sub-Q injections is not every day. It's more so on a weekly or monthly basis. However, of note, there have been no documented incidents of B12 overdose, so that may not be too much of a concern, but just note weekly or monthly for the IM and deep sub-Q. And then some labs to consider with vitamin B12 deficiency, just so you are aware, the normal B12 level is around 200 to 900, but different labs and different hospitals may use different ranges. This is a macrocytic type of anemia, so that MCV, or mean corpuscular volume, will look larger, so the average size of the red blood cells looks larger. And typically what you're going to do is you want to check these values again in 2 to 3 months after starting treatment, because even though the reticulocytes or the immature red blood cells may start ramping up after a few days to a week, the mature red blood cells may not normalize for a little bit longer. It's going to take at least a few weeks. So next we'll talk about folate deficiency anemia. So this is again an anemia where if patients have digestive issues and cannot absorb the nutrient, that can lead to it. Alcohol is a big thing, so any of our patients that come in with alcohol withdrawal symptoms or a history of alcohol abuse, we're going to put them on thiamine. Hemolytic anemia, some medicines, unhealthy diet, and dialysis are other causes. So next we have a slide here showing just which patient populations definitely need folate supplementation. These include patients with alcohol dependence, women of childbearing age, pregnant women, as well as patients with malabsorptive disorders mentioned in the last slide, where they may have GI issues. So the recommendation here is 0.4 to 1 milligram of folic acid daily for these patient populations, although it's pretty healthy for just the general population to get that as well, but definitely in these patient populations. Now, in women of childbearing age and pregnant women, the concern is that we can have some spinal deformities in the unborn infants if they don't get enough folate. But of course, anemia can also be an issue in any of these populations. And of note, like B12, if you do see anemia in these patients, it'll typically be a macrocytic anemia. So again, that MCV is larger than the normal range. Next, we'll talk about the anemia of chronic disease. So these patients are typically caused by more long-term illnesses or infections. So maybe they have tuberculosis, HIV, endocarditis, and osteomyelitis. That's the infection of the heart and of the bone, two infections that definitely take a while to treat and are hard to penetrate. Cancer as well, and then a multitude of inflammatory disorders that are listed here on this slide. So these labs are some ways that you may be able to tell an anemia of chronic disease and differentiate it from iron deficiency anemia. Main thing to look for here are the total iron binding capacity and ferritin. So your total iron binding capacity will usually be below normal, since iron stores are going to be elevated in these patients, and that was normally opposite compared to iron deficiency anemia. And then in this case of anemia of chronic disease, your ferritin is normal to high, whereas ferritin is typically low if you have iron deficiency anemia. All right, and finally, I will talk real briefly on sickle cell anemia. And this is a lot of topics for this anemia pre-lecture, and there's a lot to go through. So again, this PowerPoint is really just hitting some of the highlights. Anemia is a very in-depth topic that really takes a lot of practical experience and many lectures to get a full grasp on, but hopefully these touch some of the main highlights that are important for your class and your practice. And with sickle cell anemia, this is a malformation of the sickle cells, or the blood cells, to where they look like sickle-shaped and essentially tend to stick together and may cause some clotting as well as other issues in the circulatory system. Now, the main thing with sickle cell anemia I wanted to touch on was just this drug called Hydroxyurea. This is one of the most common treatments. It affects DNA replication, so it affects fast-producing cells like the blood cells, and it's pretty much a frontline treatment as far as what you'll see a lot of kids on and adults as well as they survive into adulthood with sickle cell anemia. And the main thing to know about this drug is that it can cause myelosuppression, or essentially decrease the levels of all your blood cells, red blood cells, white blood cells, everything. So I've just included some lab levels that cone tracks when a patient comes in with hydroxyurea, and essentially if they meet any one of these 4 parameters, we stop the medicine. So these may be different at each institution, but I just wanted to touch on that real briefly as something you may want to watch out for in your sickle cell patients. Now, there's a lot of other components of sickle cell as well, such as pain management, possibly infectious issues in younger kids. But for the purposes of this anemia lecture, I wanted to focus on this one medication that could affect your blood cell lines.